Hi all, this video is meant to be a brief and basic overview of cardiac and pulmonary conditions that you may run into if you're working in a healthcare field. I do want to start by saying if you want to know more about any of these conditions, either more details or know additional cardiac, pulmonary, or hematologic conditions that can occur, your textbook, Medical SLP, a desk reference, will be very handy. There's a lot of different definitions about conditions, procedures, causes, symptoms, things like that, that you can find in Chapter 9. Chapter 11 also touches on some different conditions that you will likely find if you're working in an acute care setting, or if you're ever working in any sort of ICU or critical care setting. So definitely check out those chapters if you're interested in learning more, and have them in your back pocket as a reference in the future. All right, we are going to get started with cardiac conditions. So the first cardiac condition that we'll start with is coronary artery disease, which is abbreviated as CAD in a medical chart. This is a condition where the coronary arteries struggle to send sufficient blood, oxygen, or nutrients to the heart. This is a very common condition, and it often develops over time, so over decades usually. Causes of coronary artery disease are plaques or cholesterol deposits that are in the heart arteries and inflammation, diabetes, hypertension, a sedentary lifestyle, tobacco use. So those are all things that you might also see co-occur with coronary artery disease when you're doing a chart review and looking at someone's past medical history. A lot of times those causes go hand in hand. Symptoms of a flare-up or an issue with coronary artery disease would be chest pain or angina, shortness of breath, fatigue, or a heart attack. So coronary artery disease is diagnosed by a physical exam, which a physician or a cardiologist would do in an office or in the hospital. They also use blood tests, echoes, EKGs, or stress tests to diagnose. So if you're not familiar with those procedures, an echo is a test that uses electrodes to measure how the heart's chambers and valves are pumping blood through the heart. An EKG, which you might also sometimes see abbreviated as ECG. This is a test that records the electrical signal from the heart. And a stress test would be a test, so that this would usually be done more in an outpatient setting, but the patient or the individual will be walking or riding a bike or something like that, and the stress test is measuring their heart rhythm, their blood pressure, and their breathing while they're doing that exertion or exercise. The coronary arteries are major blood vessels that supply the heart. So having this plaque buildup or inflammation can be very detrimental to someone. So usually treatment for this is lifestyle changes are encouraged. It can also be treated with medications, such as medications that are helping with blood pressure or cholesterol. Those can help manage this disease. Congestive heart failure, which is abbreviated as CHF, is another cardiac condition that you'll frequently see. So this is a chronic condition where the heart is unable to pump blood sufficiently. CHF is staged, so it's either stage A, B, C, or D. And there's a high risk of developing heart failure, or, it kind of goes from developing heart failure all the way to advanced heart failure. So the stages get kind of progressively worse as you go. Causes and symptoms. So causes of CHF are coronary artery disease, like we just talked about, myocardial infarction or MI, which we'll talk about on the next slide, cardiomyopathy, congenital heart disease, diabetes, hypertension, arrhythmia, kidney disease, obesity, tobacco use, drug abuse, or even some medications like chemotherapy. And some of the symptoms are similar to what we just talked about with CAD, shortness of breath, fatigue, edema or swelling in the ankles or legs or abdomen. Somebody could experience weight gain, like a rapid weight gain, heart palpitations. They might have a dry and hacking cough, a full or hard stomach, and need to urinate when lying down. And I will say, so a lot of times people with CHF are on diuretics. So this is a medication that's used to treat fluid retention. So all of that like edema, that swelling that they have in their ankles and legs, that full hard stomach is usually fluid retention. So these people might be on a diuretic. So Lasix is a common one that you'll hear, but it's like a pill that essentially gets rid of some of that fluid retention. So they might urinate to get it out. So the reason that that's important to us is that somebody who is taking Lasix or any diuretics might need to get up suddenly to go to the bathroom, like during a therapy session. So this is always someone that you want to know their mobility. So you're able to, get them up into the bathroom if you need to quickly, or have the nurse on standby to come really quick, or have them go right before your session. Just something to think about from an SLP perspective. Diagnosis and treatment. So again, a physical exam, blood test, the echo and EKG that we talked about, a stress test. They also will do an ejection fraction, which is, you'll see this in the chart as EF, and it'll give like a certain percentage. So the percentage, this is measuring how much blood in the left ventricle is pumping out. So this kind of speaks to the severity of the condition. It can go up and down. So that normal range is around 53 to 70%. So you'll see that like a cardiologist note will have their EF listed. So if it's not in that range, it's either too low or too high. And then CHF is also treated with some of the same lifestyle changes that we talked about with CAD, blood pressure medications, cholesterol medications, ACE inhibitors, beta blockers, diuretics, like we talked about. Sometimes these individuals will be on salt or fluid restrictions, which again is important for us to know in case you're doing a swallow eval. You want to be careful with diet-wise what you're bringing into the room. All right, so I don't want to go through and just read off all these slides to you, so I'm going to start kind of summarizing them a little bit more. But acute MI, myocardial infarction, is a heart attack. That's kind of what you know as a heart attack. And a heart attack happens when blood flow is blocked due to a buildup of plaque in the arteries. So it's cutting off blood and oxygen to the heart. So someone who's having an acute MI or a heart attack is going to have sharp chest pain radiating to their jaw, shoulders, and arms. They're going to have that shortness of breath, diaphoresis, which is just the medical way of saying excessive sweating. They might also have nausea and vomiting, or a temporary loss of consciousness. Diagnosis and treatment is similar to what we just talked about. They might also do a lab analysis for enzymes. And then in the case of an MI, they're going to want to treat pretty immediately with medication, with oxygen, with different IV therapies or IV drugs to help manage pain medication. And that kind of decreases the workload and oxygen demands of the heart. They might even do medication like the beta blockers that just kind of promote blood flow. They improve blood supply, prevent arrhythmias, and things like that to help get that person back to a stable point. I know I said I wasn't going to read the slide, and then I pretty much did for that, but I'm going to try to summarize more. All right, so the next cardiac condition we'll talk about is cardiac arrest. So this is different from a heart attack, but those words are often used interchangeably. So just kind of be aware of that. Cardiac arrest is something that could happen after a heart attack or maybe even during the recovery of a heart attack. And this is something that's very sudden. So this is an electrical malfunction. So an electrical malfunction happens in the heart. It causes an arrhythmia, and the heart cannot pump blood to the brain, the lungs, any of the other organs. So if cardiac arrest is not treated within like minutes, that person would die. So symptoms for cardiac arrest would be a sudden collapse with loss of consciousness. They're not going to have a pulse. They're not going to be breathing. Some signs that you might see someone have right immediately before would be chest discomfort or shortness of breath, heart palpitations, but it can come on very suddenly. And this is treated with CPR or an AED. And then the brain damage can occur, obviously, because that person is not getting enough oxygen or any oxygen to their brain. So these are people that can, or individuals that can end up on a speech therapy caseload for a cognitive eval after the event. Acute pericarditis is sudden inflammation of the lubricated sac that encases the heart. For someone with this condition, their pain is going to be worse if they're laying down or if they're breathing in. The causes and symptoms are listed on there. It can be idiopathic, it can be caused by infection, connective tissue diseases, and they're going to have some of this, some of the similar symptoms to what we were talking about for the last few conditions. This person might also experience hiccups, would be kind of like a more hallmark sign for this being a problem. And then as far as diagnosis and treatment, physical examination, some of the other imaging studies that we've talked about before. And this can be treated with medication or a pericardectomy, which is a surgery. And that surgery is one that removes all or part of the pericardium, or it can be treated with pericardiocentesis, which is a fluid extraction. So that method is usually used more if the cause is infection or cancer. All right, we have an aortic dissection next. So this is a tear in the aorta that allows blood to accumulate in the lining. So this can be lethal if the blood goes outside that aortic wall. This condition is most common in men in their 60s to 70s. And there are several causes: hypertension, hardening of the arteries, genetic diseases can even cause this, or aortic valve defects. Chest pain is one of the symptoms that person could have, and it presents more in like a tearing or kind of ripping sensation. That person might also experience leg pain or difficulty walking, and some of their symptoms might show up as stroke-like symptoms: visual deficits, difficulty speaking, weakness on one side of the body. Diagnosis and treatment. So TEE is a new test that we're seeing here for this, but TEE is a transesophageal echocardiogram. For this test, an ultrasound probe, it's guided through the esophagus into the heart. It uses sound waves to create pictures of the heart in motion. So that's one thing that they can do to diagnose. And an MRA, we've talked about MRIs before, but MRA uses a magnetic field and radio wave energy to create images of the blood vessels. And this can be treated by medications. So some of the beta blockers, like we've talked about before, or antihypertensives, or also surgery. The important thing to know with surgery is that complications in surgery can lead to a stroke. Endocarditis is another cardiac condition that you'll run into pretty often in the medical field. This is inflammation of the endocardium, or the inner linings of the heart's chambers and valves. Arrhythmias are also very common. Arrhythmia is just an irregular heartbeat. It can be the rate or the rhythm that are irregular. And two things that you'll see a lot in medical documentation is tachycardia, or you'll hear nurses say like, "Oh, that patient's tachy." That means their heart is probably beating too fast. And then bradycardia, on the other hand, is too slow. So again, you'll see that in the charts quite often, or you'll hear doctors and nurses referring to patients as tachy or brady. That's just referring to the rate of their heartbeat. AFib is like a condition that's kind of tied to this, and you'll hear that people are like in AFib, atrial fibrillation. This is a chaotic heart signaling. So this is just kind of a rapid, really uncoordinated heart rate. It can be temporary, but oftentimes it might not stop until it's treated. A pericardial effusion is fluid accumulating in the pericardial space. This can result in cardiac tamponade, or excess fluid that's increasing pressure on the heart, that's then preventing the heart chambers from filling completely with blood. You might hear or see somebody in a hypertensive crisis. This would be a sudden and severe increase in their blood pressure that can cause intracranial hemorrhage, MI or heart attack, pulmonary edema, aortic dissection, or renal failure. And then angina, you'll hear talked about too, or see in medical charts, and it can be classified as either stable, so that's like predictable chest pain, and that would be like when someone's exerting themselves or feeling stress, or it could be labeled as unstable, and this would be chest pain that occurs just when someone's at rest or with exertion. It worsens in frequency and severity. It's just a little bit more unpredictable. So you may see that as well. All right, so some common cardiac procedures that you might also see or hear about in medical charts. Stents are placed pretty often. A stent is a small mesh tube. It's used to kind of hold open a passage in the body, such as a weak or a narrowed blood vessel. A cardiac cath is a small catheter, and that's what a cardiologist or surgeon would use. They insert it into the heart to do more testing, exploration, to find out more. So that might be used for part of the diagnosis. Balloon angioplasty. So this is another catheter that's inserted into the heart, but there's also a tiny balloon that's attached to it. So this is kind of carefully guided. It goes through the artery over to where the blockage is, and the balloon is inflated a bit, and this kind of widens the opening and it increases blood flow to the heart. Coronary artery bypass grafts, you'll just hear that called CABG. So, and somebody might have CABG times 2 or CABG times 3. This is like a heart bypass or a bypass surgery. So this is a surgical procedure. It improves blood flow to the heart by rerouting blood around blocked or narrowed coronary arteries. So the CABG times 2 or times 3 or times 4, that's just essentially how many coronary arteries that they are having to do that procedure on, or, when they're in there, how many they're having to bypass. You'll also hear about implants. So an implant refers to something like a pacemaker, a defibrillator, an LVAD, which is a left ventricular assist device. So those are all other things that you'll see in our patients that experience cardiac conditions. And the carotid endarterectomy we talked about a couple slides ago. So why is this important to us? Considerations that you need as an SLP are to pay really close attention to precautions. So a cardiac patient who just had surgery or is about to have surgery, they might have sternal precautions. They might have activity precautions, like whether or not they can get out of bed or how high their head of bed can be. They might have to hold a pillow against their chest when they're coughing or exerting themselves at all. And they might also have diet restrictions, like we talked about before, fluid restrictions, sodium or salt restrictions. So those are good things to pay attention to if we're doing anything with swallowing. Some conditions, so something like CHF, can require modifications of activity immediately after eating, like maybe they have to sit up for a certain amount of time or something like that. So we really want to be aware of things like that. I do also want to say, so patients a lot of times with CHF have like a very wet sounding, they just kind of sound wet. So when they're eating, when they're talking, and like, that's that person that has like all of that fluid retention. So to us, when we're listening, and we're like, oh, that's a wet vocal quality, or, it can be confused because, and you don't know, right? You don't know if it's fluid retention or if it's aspiration or penetration. So that just reinforces further the need for things like fees and MBS, so we can really see what's going on, and we're not just trying to guess based off what we hear. You also want to pay attention to edema, so swelling. So just say you're doing a therapy session and that person is experiencing like increased edema. If they start sweating profusely during your session, if you're noticing an increase in their respiratory rate, or cyanosis. And cyanosis is just kind of a bluish cast to their skin. So maybe they just don't look, their skin doesn't look healthy or vibrant like it usually does. And then our cardiac patients overall usually have pretty poor endurance. So you'll want to think about that too, as far as when you're scheduling therapy sessions and how long they are and things like that. All right, we're going to move on to pulmonary conditions. So we'll go through a couple of these. And again, I'm going to try very hard not to read off the slide because I know you can all do that on your own. But the first thing that we'll talk about is ARDS, acute respiratory distress syndrome. This is a condition where fluid collects in the lungs air sacs and deprives the organs of oxygen. So ARDS can be caused by sepsis, by inhalation of a lot of smoke or chemicals, by aspiration of vomit. You'll see this in near drowning cases, severe pneumonia cases, traumatic injuries. So a lot of traumatic injuries like to the chest or core. And it can also be caused by COVID-19. So somebody with ARDS is going to experience severe shortness of breath, acute dyspnea, low blood pressure. They might be very confused or extremely fatigued. And ARDS can cause a lot of complications. So it can cause blood clots, pneumothorax, infection, pulmonary fibrosis, cognitive decline, fatigue, and depression. So they're all these are definitely folks that can wind up on our caseload. ARDS is diagnosed by physical examination, by a pulmonologist, by a critical care doctor, also by chest X-ray or CT scan of the lungs, EKG and echo, like we talked about previously, and then also differential diagnosis with other pulmonary conditions. And it can be treated with supplemental oxygen. Somebody with severe ARDS might also need mechanical ventilation. They'll also be managing and looking at fluids for this person and treating with medication. ECMO is something that not all hospitals have. Some do. I think Mayo Clinic in the Valley has ECMO. I want to say the University Medical Center. So anyway, some of the bigger hospitals do have ECMO, but this is a very specific treatment. It's called extracorporeal membrane oxygenation. And for this treatment, the blood is actually pumped outside of the body and it goes into a machine that removes the CO2. And then the oxygen-filled blood is sent back into the body. And so essentially, it's like this machine is doing all of the work for you. So that gives your heart and lungs time to heal. This is used in critical care situations. They use this for some of the severe COVID-19 cases. And you'll see it used in other, like in cases of ARDS. So it's not a treatment that you'll see in every hospital, but it is something that you might run across depending on the facility that you're in. COPD is big on our caseload. So this is chronic obstructive pulmonary disease. This is a chronic inflammatory lung disease that obstructs airflow from the lungs. It's commonly associated with emphysema or chronic bronchitis. It can be caused by smoking, exposure to fumes, and poor ventilation. Somebody with COPD is going to have shortness of breath, wheezing, chest tightness, a chronic and productive cough, maybe frequent respiratory infections. They might have a lack of energy, unintended weight loss. Swallowing and eating can be very hard for someone with COPD, especially in the later stages, because it's very hard to coordinate swallowing and breathing. So they just maybe don't eat. And somebody with COPD can also experience edema in the lower extremities. So COPD is diagnosed by a physical exam, pulmonary function test, chest X-ray, ABGs, like we've talked about before, and then different labs to kind of determine the cause. And people are, guided for treatment by lifestyle changes, like quit smoking if they're smoking, using inhalers, using different medications, being on oxygen. In the worst cases or more severe stages, a lung transplant might be in order. But yeah, COPD, and it's classified in different like stages. So that's also something to think about, what stage of COPD they're in. Yeah, but that will definitely pop up on our caseload quite often. Emphysema is another condition that you'll frequently see pop up on our caseload. Chronic bronchitis as well. So those bronchial tubes are really inflamed and narrowed. So with these conditions too, you'll see that people have, they might end up with a chronic cough or a chronic throat clear. So again, those are things, especially if you're someone that's specializing in voice and swallowing, you might work with that quite often. Pulmonary embolism, or a PE, this is a sudden blockage in one of the pulmonary arteries in the lungs caused by blood clots. So it's most often by a blood clot that originates in the leg, so a DVT. So essentially that blood clot maybe is in the leg and it is thrown and gets up into the pulmonary arteries, and then all of a sudden it blocks that. So the person is suddenly not able to breathe. DVTs are frequently managed, or people try to remove the risk of DVTs or blood clots in the legs by using SCDs. And you'll see those if you're working in like an acute care or a rehab. This is a sequential compressive device. So it's a machine, and you'll see this like on hospital beds. So it's like they have like a little cuff that wraps around the legs, and that's attached to a machine. And it's just like frequently squeezing that person's leg or their feet. And that's just to prevent blood clots. So just, getting that blood flow going if that person is sitting in one spot or laying down in one spot for a very long time. You'll also see people like wear like compression socks or things like that, the compression socks that go like all the way up the leg. Um, and same thing, it's just to prevent blood clots because blood clots can obviously be very dangerous and can cause stroke and PE, and a lot of bad things. So, causes of PE, heart disease, cancer, surgery, different blood clot disorders, COVID-19, prolonged bed rest, or, a sedentary lifestyle. If someone's not able to get up, they're bedbound, maybe smoking, and also pregnancy. And then symptoms, shortness of breath, chest pain, cough, bloody sputum. But this is if someone is experiencing a PE, or if they have a blood clot, they need immediate medical attention. Or the alternative is death. So this person will be treated with a physical exam, blood test, chest x-ray, a pulmonary angiogram. So this test is one that gives a clear picture of blood flow in the lung arteries. This is the most accurate way to diagnose, but it requires a lot of skill to administer it, and it has some high risks. So this isn't something that would necessarily be available at everybody's hospital or facility. And then the treatment is going to be to prevent that clot from growing or from any new clots to form. They would use medications. And in some cases too, that person, if they can catch it, would go to surgery and the clot would be removed, or maybe like a filter would be put into their vein to prevent further clots. But a PE it's a very serious condition. They all are, but a PE it does need immediate medical attention. Pneumothorax is a collapsed lung. And this is where air is leaking into the pleural space. This could be caused by iatrogenic errors. So this would be something like an illness that's caused by a medical exam or treatment. So for example, their lung was punctured during surgery. It could be caused by trauma. So a gunshot wound or a car accident that can cause pneumothorax. Even mechanical ventilation. So if somebody's on a ventilator too long or on too high up settings, it could cause pneumothorax. That person will experience shortness of breath and chest pain. And then the treatments are listed there too. Sometimes it's just time. Sometimes they'll actually aspirate some of that air, put in a chest tube, or that person might have surgery. And aspiration, we're all pretty familiar with, but a foreign body or substance enters the airway. So this can be caused by dysphagia, as we all know a lot about. Also by drowning, asphyxiation. So again, like aspirating on vomit would be an example of that. Reactive airway disease. This is a general term that's just kind of to describe a set of symptoms that may or may not be caused by asthma. A lot of times reactive airway disease is used as a placeholder. You'll often see it in pediatric notes. If that child, maybe they're not old enough to be adequately tested for asthma, they might use reactive airway disease kind of until they know more. And then asthma is a disease of the lungs in which your airways narrow, swell, might produce extra mucus. Asthma can be exercise induced. It can be occupational, allergy induced. And it's usually treated with medication or having that person avoid their triggers. An upper airway obstruction is something that you might also see on your caseload or in the medical system. The narrowing of the airway leads to a compromise in ventilation. So this could be caused by a couple different things: tracheal stenosis, tracheomalacia, by trauma, by a tumor, by foreign body aspiration, an allergic reaction, an infection, swelling of the tongue or epiglottis. So there's a lot of things that could cause an upper airway obstruction. And that person is going to experience a stridor, cyanosis, that bluish cast to the skin, confusion, agitation, gasping for air. And this can be diagnosed with chest x-ray or a CT, a bronchoscopy, a laryngoscopy. And depending on what the cause is, it could be solved with the Heimlich maneuver, with epinephrine, with CPR, with surgery, kind of depending on, what the cause is. All right, and then we have COVID, which we all are also pretty familiar with, but these are coronaviruses or family viruses that can cause illnesses. So that is something that you will also see in the hospital. It's spread by respiratory droplets, and there's a very, very wide range. So somebody can be asymptomatic all the way to severe. And then the other thing I wanted to talk about with COVID is that now a lot of, if you're working in an outpatient setting or maybe even a home health setting, or like a long-term care facility, there are people who are, and there's more research coming out about people who are experiencing symptoms of long COVID. So that could be neuro symptoms like cognitive decline, where people still feel a little hazy, they're experiencing attention deficits or memory deficits. People that experience respiratory symptoms long term or immune systems symptoms long term. So I don't know, we are learning more and more about it, but it's good for us to think about the impact that that has on patients. So pediatric through adult, how COVID, changed things or how it continues to impact people. And our role, I think that we're still kind of figuring out best practice. So for now, if you have somebody in your office with neuro or respiratory or immune symptoms, I think we are just treating in the ways that we know how to treat those symptoms. But there's not a lot of very COVID-19 specific treatment methodologies. So you would treat them how you would treat others with those symptoms. But anyway, I'm sure there's more research to come, but it's interesting to think about. And there's a lot more coming out. All right, so considerations for pulmonary folks, again, being aware of precautions. So somebody with a pulmonary condition, they might have respiratory precautions, they might be on oxygen. Again, they might have mobility precautions. Maybe they're on room air in their room, but if you're walking them down to the rehab gym, they need oxygen or they need their nasal cannula. A lot of times this population would benefit from being up in a chair for meals if they physically can. Sometimes you can even have the pulmonologist put in an order for that. So like up to a chair for meals, because we know if breathing is difficult, it makes swallowing difficult too. Like we were talking about the COPD population, it's really hard to coordinate breathing and swallowing. So if we know someone's having trouble with breathing, we want to, make swallowing as easy as possible. You really want to pay attention to vitals and alarms. So, remember common sense. So if you're looking at somebody's, O2 sats or something and it's all over the place and it's, up and down and it's 20%, it's 40%, it's 90%, it's 100%, it's, and then you realize that they're eating a meal and they're holding a fork and the finger is the one that has the pulse ox on it. Well, that's probably why you're getting a bad read because it's not an accurate read. So you want to look to see where that pulse ox is attached. Maybe if they're busy with their hands, maybe you could move that, move the pulse ox down to their toe. Or in the hospital, they have like a sticky one. So I've seen it stuck to someone's forehead or to their earlobes or, another place if the one on their hand is not getting a good read or it's bothering the patient a lot. So that's something you wouldn't do on your own, but it's something you could definitely talk to the nurse about and problem solve together. So you want to obviously be looking at vitals and alarms all the time, but just look around your environment too to make sure that you're not getting a wrong or inaccurate read. And then baseline vitals are essential. So especially for someone with COPD. So maybe, or this is a good example. Somebody with COPD might not ever have 100% O2 sats. They might not ever. Their baseline might be 90 or 92. So when you're in the room and all of a sudden you look at their oxygen, maybe like halfway through your session, and you're like, oh my gosh, they're at 92. They've dropped 8%. What's going on? I better go get the nurse. I wonder if they're aspirating. I wonder, and you kind of start to panic, but then you go and you look back in the chart or you talk to the nurse and they're like, oh no, they're always at 90 or 92. And then it's like, oh, okay, that's just their normal. So you always want to know what that person's normal is because 100% might not be normal for everyone, especially people with pulmonary conditions. And then kind of like we talked about with CHF, some pulmonary conditions can also sound like aspiration. They might sound very wet and wheezy, and you're thinking it kind of has something to do with their swallow, but it doesn't necessarily. So just kind of keep that in mind. Again, another argument for why we need instrumentals. All right, that's it. That's all I have for you. So here are references and resources, and I will see you all in class.